right. Hello, everyone. Welcome. Thank you so much for taking the time and joining us today. Very excited to have you with us. My name is Daria, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is an introduction to knee ultrasound, and our speaker is Dr. Shirish Sachdeva. Dr. Sachdeva is a practicing physical therapist in Indiana. He's also licensed in New York, Maryland, and he has 15 years of experience from various types of settings, including orthopedic and neurology hospitals, ICUs, nursing homes, wellness centers, home care, and orthopedic outpatient clinics. He's also certified in needle EMG and CV from College of Staten Island and point of care ultrasound MSK certified by POCUS Certification Academy and RMSK certified by AirDMS. I'd like to welcome Dr. Sachdeva. Thank you so much for taking the time to present to our global audience. We're very excited to hear about your topic. Welcome.
Thank you, Daria, for having me here. And as I understand, the audience is from everywhere around the world. So I thank all of you for taking it, time to come and visit and listen to us on this webinar. Thank you. Appreciate it. I'll go ahead and start with our presentation. So Daria, I'm going to start sharing the slides here. So welcome again, and I will, without any ado, start the presentation. Just a little bit about myself. First, I would just like to give thank you to all these places associated with me, these organizations that I have been with and learned from. Because of that, I have been able to earn a lot of relationships and educated and come to the point where I'm presenting to you guys. I've been practicing for 15 years as a PT and 10 years as in diagnostic sonography. I don't have any financial conflicts related to this presentation. The presentation is primarily for educational purposes, and I would also say that these images presented here are part of my communication and direct interaction with patients, and they're all de-identified, presented to you with patient consent. And the role of physical therapy in ultrasound is a good question. PT is a direct access profession in the United States. And I think the role of diagnostics cannot be understated in any value, including the point of care ultrasound in our clinics. It helps us evaluate PT evaluations and solidifying the plan of care and screening as well as triaging. It does help us in managing these plans and decision-making process where we can examine different type of conditions like soft tissue damages, fractures, core activation biofeedback, dynamic evaluations including listhesis, joint health, as well as myositis ossificans, to state the least. And this type of evaluation becomes so concrete that it also helps us gain the patient's buy-in through the whole process of physical therapy, as well as makes it a lot more confident for physical therapists to do this job better. And it also helps us in performing these invasive procedures like dry needling. And it obviously has shown a lot more accuracy in the medical field as well when joint dry needling has been done under imaging. POCUS in physical therapy can also be used as biofeedback, as I said, also known as RUSI. It can evaluate nerve health. It can go on with cardiopulmonary physical therapists on day-to-day basis and then their day-to-day use, as well as in pelvic health. It has a major role. We have a good amount of institutional support for use of ultrasounds in physical therapy. The APTA and the American Orthopedic Physical Therapy Association with their imaging SIG, I really have gratitude towards these guys working day in and day out tirelessly to bring imaging to the mainstream in PT. I would also like to acknowledge our great relationship with AIUM and Intellios and all its branches, including POCUS Academy and APCA, in supporting the MSKUS use within physical therapy. The Department of Defense came out recently stating that physical therapists are the neuromusculoskeletal experts in their field, and the FSBPT also supports the use of imaging on day-to-day basis within physical therapy. The learning objectives for this specific webinar today are to interpret the findings of the knee joint and comparing normal to abnormal structures, as well as knowing some causes of pain. Plus, it also helps you kind of integrate that within the plan of care, as well as triage the patient as needed. The anatomy of knee joint anteriorly in tendons shows us primarily the quadriceps muscles and tendons, which include these four muscles: the vastus medialis, intermedius, lateralis, and the rectus femoris, performing the extension of the knee, and the patellar tendon from the inferior pole of patella going all the way to the tibial tuberosity. And you can note that on that image as well. Going on to the posterior aspect, where you're looking at primarily the hamstring muscles. You look in biceps femoris, more so on the lateral side. On the medial end, you'll see the semitendinosus and semimembranosus, and the popliteus can be seen as well, which rotates the tibia medially on a fixed femur and rotates the femur laterally on a fixed tibia. While the rest of those hamstrings are causing flexion of the knee, the medial and lateral gastrocnemius also cause knee flexion and are more caudal to the imaging, and also allow for plantar flexion of the ankle. Again, those can be notified on this image as seen on your right side. When you move on to the medial end of the knee, you can see the pes anserinus tendons in here, including sartorius most anteriorly, gracilis, and semitendinosus in the same order, where the average tendon width of these tendons in literature is described as 8.0, 8.4, and 11.3 millimeters respectively, in the same order as you see on the screen. The most anterior one, as I said, is sartorius, which is also the longest muscle in our body, known as a talar muscle, and it does the flexion of the hip and the knee. Looking at lateral side, you're seeing the iliotibial band, the IT band, causing the abduction or helping the abduction of the hip, while the biceps femoris tendon is also noted there. And it is a bifurcated tendon. I'll get back to this in its clinical relevance as we go on in the webinar. The ligaments that we note in the knee joint are the cruciate ligaments, ACL and PCL, which are the internal ligaments inside the joint. And then you see the collateral ligaments, which are on the lateral and the medial end, the medial collateral ligament and the lateral collateral ligament. I sometimes also like to note the medial patellofemoral ligament as it has the relevance in terms of patellar dislocations and subluxations. The meniscus that we notice are two primarily discoid structures, and we have one on the medial side, the medial meniscus, and one on the lateral side, both of them having an anterior and posterior horn. The relevance of this is to evaluate the horns in their complete view from anterior to posterior on both sides in cases of possible damages to the meniscus. There are a lot of bursas in our knee, if you notice, and the ones that I mostly look for are these on the left side. These ones are most commonly irritated when you're looking for a bursitis type of pain. So when they get inflamed, you look at these specific ones: suprapatellar bursa, the prepatellar bursa, iliotibial bursa, pes anserinus, close to those pes anserine tendons we just talked about, the infrapatellar bursa, which are superficial and deep types. Some of these issues that we note on the ultrasound, as I mentioned there, it's not an exhaustive list. There are a lot more things that can happen in the knee joint, but we'll touch a little bit on these issues as we go along the presentation. The tendon and muscle injuries include the patellar and quadriceps tendon that I'm going to show about, but this can be related to any other tendon as well. As you note, collateral ligament injuries are more specifically noted on the ultrasound. Why I mentioned that is because the ACL and the PCL ligaments are hard to visualize 100% on the ultrasound. PCL is a little bit better, but ACL is super hard. So sometimes it is difficult to get patients into that position to note them. MRI is a lot more specific for that. Meniscal tears, we're going to note those as well. The medial and lateral meniscus tears, we'll look for those. Cysts, Baker cyst is one of the most common ones to note for. Parameniscal cysts are present in times when there are meniscal injuries. Joint effusion can be a common finding in any type of issue in the joint. Anything intra-articular can create some effusion there. Chondrocalcinosis, deposition of some calcium around on the cartilage, and bursitis, plus fractures and avulsions can be really clearly seen, especially the periosteal damage can be seen on an ultrasound. The probes that we would use in ultrasound, primarily I use these two type of probes, the linear head and the curvilinear head. The linear head has a high frequency, but it has low penetration depth. So because of this, you can't see a deep structure with a linear head, but you get a really good quality of imaging with 4 to 18 megahertz. There are some higher megahertz also available, like 22 and so on. They're used mostly in small joints. While curvilinear probe can be used for people with a larger body habitus. Sometimes with posterior joint imaging, I use the curvilinear probe just to get a better image and a wider image on a trapezoidal view. But primarily, these are the two ones that you need for MSK imaging for the knee joint. Anisotropy, I think I can't go ahead without touching on this one, where it is an artifact in the ultrasound imaging. I kind of look at it on the left side of the image. If you see, I kind of put in a little small little peephole from a door. Many times I explain this, that anisotropy can be understood while looking through a peephole. If you notice right in the center of that peephole, the door shows in the middle with its best proportions. But as you go to the periphery of this peephole, you start seeing the proportions getting a little bit more distorted. Because of that, it's the same kind of a visualization on an ultrasound. When you are tossing those ultrasound beams at a 90-degree angle to a structure inside the joint, I see that you would notice a fish inside someone's arms, and I hope that is not the case. But if you're trying to look at that fish bone, you're going to see the center of the body of that fish bone best seen when the beam is going at 90 degrees straight to that structure, and it bounces straight back to the ultrasound probe, which it picks up. The moment you kind of tilt that probe in different angles, it tends to divulge that beam in different directions, and it doesn't return back to the probe, therefore giving the illusion that the structure does not exist. This is primarily what anisotropy is. Going on to the normal sono-anatomy at this point. So we want to see how a normal knee looks like. And in that case, we're looking at the knee joint. Again, I'm picking an example of the patellar tendon here, where you'd notice how the superficial portion of that screen shows colored on the left side with blue. That is the hyperechoic skin that you'd notice on the top, which kind of turns a little hyperechoic as you go down. If I'm pointing out right, I'm talking in this screen here, kind of corresponds to that area. And then we're looking at the subcutaneous tissue, which could be fatty and shows a little bit more hyperechoic. The tendon has fibrillar fibers. As you notice, they go from this inferior pole of the patella to the tibial tuberosity, which is hyperechoic or sharp in its view. And at the bottom here, you see the Hoffman's fat pad. Fat pads are normally, again, mixed echogenic presentation with hyperechoics, fibrosis around hyperechoic fatty tissue. You go on and look at the view in a longitudinal view. This is long axis view of a muscle. So here you're looking at, again, the skin, which is mentioned out here, again, hyperechoic a little bit. Then you go to the hyperechoic subcutaneous tissue, plus these fibrillar echotextures of the muscle. And intermediately, you see an intramuscular fascia here with a bright line echogenic presentation seen on both views. And when you move on to the same muscle in short axis, you see how this muscle looks with a starry night appearance. This is how we kind of portray it, with the dotted appearance, and the intramuscular fascias show up with these bright echogenic presentations. And on this side, you notice the associated bone right on the side of that muscle. As we go ahead, we're looking now to evaluate the quadriceps tendon in that long axis view, where what you're looking and visualizing is definitely the tendon itself, which shows up from here to here. These are the fibers of the tendon, which sometimes show up in 3 different bands being made by the rectus femoris, the vastus intermedius, and vastus medialis, and the lateralis. You also notice here are these hyperechoic 2 structures, which are the fat pads. One of them is a prefemoral fat pad, which is close to the femur, and the other one is a suprapatellar fat pad, also known as the quadriceps fat pad, just under the quadriceps tendon. And as you go on in evaluating this joint dynamically, you can see suprapatellar anterior joint recess kind of filling up a little bit and moving. So it's always good to evaluate structures dynamically. And sometimes if you are suspecting fluid in this area, you can note that. If you watch this video going, you see how this joint kind of moves in flexion and extension. And it shows up how the femoral cartilage kind of pops up between the 2 fat pads and separates them. Sometimes there can be fluid in here. And if there is, what you could do is a procedure called milking of the joint. You can actually push the medial lateral sides of the patellofemoral joint and try and push the fluids more towards the cephalad direction, and that tends to push this fluid out into the anterior joint recess. As you go on, you can evaluate the same tendon in a short axis view. As you're doing so, the knee is kind of kept as, at a 30-degree angle, just like the previous one. And you see that quadriceps tendon right in the middle. As I play this video for you, make sure to evaluate the structure from all the way, medial to lateral and lateral to medial to see the consistency of those fibers and evaluate all the edges of this tissue. As you move on, you would notice we're going through the quadriceps muscle. So I made a point to kind of bring this up because I do want you to kind of have an understanding of when the quadriceps tendon's forming. It's forming from 4 different muscles. So they're all coming in from different directions trying to make that tendon. It is a strong tendon and produces a lot of force. So while training, we want to train all these muscles, and they may sometimes have ratio imbalances. So this is a good view to see that. You see the hyperechoic femur, and you notice on the medial end here is the vastus medialis obliquus. On the lateral side, you see the vastus lateralis. And right on top here is the rectus femoris, plus at the bottom of that is the vastus intermedius. To play this video for you, it kind of shows you when you evaluate this from side to side, you get to see those structures visually in a dynamic view. It's really nice to see that, because if there's any injury and any fluid accumulation on any one of those, you can separate them and work on the specific muscle group as you could. This is the short axis view of the femoral cartilage and the medial and lateral condyles, medial being on the left side of the screen and lateral on the right side of the condyles are being seen. The anechoic to more hyperechoic presentation here is the femoral trochlear cartilage that you're noticing and the overlying quadriceps tendon. Again, the knee is bent in this position. At times, as you notice, it's hard for patients to get to this position, especially in acute injuries and so on. So this may not be the view that can be attained every time. But if you are able to get to this image, the angle of this cartilage should be somewhere about 130 degrees. If it is lesser than that, it may kind of tilt the patient towards being more prone towards patellar subluxations. And you can measure, as you notice, you can measure these cartilages and see how the thickness is and how the quality of that cartilage is. The cartilage quality should be more so towards that hyperechoic, anechoic type of presentation. A hyperechoic cartilage is not a healthy one. And as you look at the anterior knee joint again, so you have seen this image before where the patellar tendon kind of sits around in that fibular ectotexture from the inferior pole and to the tibial tuberosity. That same tendon can be looked in short axis by rotating the probe by 90 degrees, and you can see this presentation of a hyperechoic tendon. This is a decently healthy tendon, and you look at it from side to side like that. And this is a study that was published in 2021 by Naredo et al. Suggesting the dynamics of half-os fat pad during knee flexion and extension. I wanted to mention this study as it may have a role in evaluating the fat pad in causes of symptomatic fat pad impingement and can differentiate between differentials like patellar tendinopathy, joint effusion, and or bursitis. There is a really nice video that they also showed, as you notice, when you dynamically kind of contract and expand that joint by knee flexion and extension, just a tiny bit of it, the fat pad kind of moves towards the patellar tendon and it tightens up the patellar tendon on top. Pushing the fat pad into the tendon, sometimes this can cause impingement. But I would also say many times, some incidental findings may occur. So if that happens, please make sure to check the asymptomatic findings of the fat pad edema, mass effects, which may not be causing anterior joint pain, and a good clinical correlation is needed for that. Now, this is a panoramic view of the quadriceps tendon, patellar tendon, and their respective attachments of the patellar and the tibial tuberosity. You may notice that the nice fibular ectotexture of both the tendons here is seen in its entire anterior joint space, and with the half-os fat pad being seen on the inferior end of the patella. This can help in making a note about the joint effusion because you see the whole joint in the proximal end and the distal end. Now, this specific picture also highlights one point where the role of toggling the probe is important to remove that anisotropy we talked about. Because if you notice on these two ends of the tendons, even at this one a little bit, you see how the tendon tends to become a little bit dark and hyperechoic from its fibular attachments here. But that's not a bad tendon. It is not having any fluid. It's just that the ultrasound beam is not hitting these at 90 degrees because of the curvature of the tendon fibers. Therefore, it should be made a point to toggle the probe appropriately to get these tendons into proper visualization. The next image here shows the medial aspect of the joint, and it shows the triangular echogenic fibrocartilaginous medial meniscus, which is hanging right in the middle of the joint here, with its attachment to the MCL ligament. So this is one of the important key points where MCL actually attaches to medial meniscus, and it's a clinical relevant point because sometimes they can get injured together. Now, one should assess the medial meniscus both from the anterior point, sweeping the probe all the way back down to the posterior end of it, and that kind of gives you a better understanding. Now, if you also notice, the whole meniscus cannot be visualized. All you're viewing is the outer, probably 1/3 of that meniscus. The deeper portions are not seen. This is where the bone doesn't allow the ultrasound to pass through, and it's a limitation of the ultrasound. So sometimes at this point, I would say MRI is still a gold standard to kind of look at a full-blown deeper meniscal tear, though you can find some alternate findings in this, but it can be done also for the lateral meniscus, to make a point here. The MCL here is connected with the medial meniscus, as I said, and it shows two distinct fibers, the superficial fibers that are going a little bit above here and the deeper fibers that attach to the meniscus. Again, this has clinical relevance as if one is testing the MCL. With your clinical exam, you can actually do the testing, the orthopedic tests, and you can find dynamically with the valgus stress test how your ligament is performing and is the joint gapping or not. As you look at the same ligament, it's a long ligament, so it goes all the way down onto the tibia. So I'm just kind of screening all the way down of the tibial attachment of this MCL on the medial side. You notice the fibrous psychotexture of this ligament all the way down till here. But also what you notice here are the pes insurinus tendons laying superficial to this region. And these pes insurinus tendons are looking more or less conjoined. But as you go a little bit proximal, you can separate them and actually visualize them in their long axis views. And these pes insurinus tendons include sartorius, gracilis, and the semitendinosus. Again, if there's bursitis, that can be viewed between the tibia and the pes insurinus tendons right about in there, and can be correlated with clinical examination. As you move on to the lateral side, in addition to the lateral meniscus, just like medially, you can examine that, but you can also look at the lateral collateral ligament. This is primarily between the femoral attachment and the fibular attachment. So as we play this video, you'll notice how that lateral collateral ligament kind of runs from here, goes all the way up, and goes to the fibular attachment right around there. So again, you want to examine this ligament in its length as well as in its short end. So you do want to notice all structures in both the views. Comes the biceps femoris tendon again on the lateral side, and you can examine this with, again, evaluating this tendon. Here I would bring the point of that separated tendon, the bifurcated tendon attached on the fibular head. You notice right around there, you can see this tendon bifurcates and the LCL kind of goes a little bit in between in there. Because of that, sometimes this tendon looks a little bit tendinosed at this attachment. Please do not understand as a pathology. Try to look at it in a little bit more depth with both views taken into account and correlate it with the clinical examination of strength testing, palpation, and all orthopedic exams to check the biceps femoris tendon. And one point I would like to make here is that you can actually examine the three structures, which include sartorius, the LCL, and the biceps femoris, all together in this single exam by following this Z approach. So the most anterior structure, which would attach onto the tibia, is the sartorius, while this little connection in between is the LCL, and the one in the back is the biceps femoris. You will examine them just as the way described before. As you move ahead, you would notice the posterior knee joint. Again, there are less times that I would examine the posterior knee joint. Most of the issues are medial, anterior in our clinics, but again, posterior knee joint comes up with a lot of pain as well here or there. I do look at this image, and if you notice, the left side is an image which shows the medial condyle of the medial posterior femoral condyle and the lateral posterior femoral condyle, and you'd see a large bulk of gastrocnemius muscle in here with the neurovascular bundle in here. And if you kind of screen a little bit through this video as I'm going more, Distally down, you could see these vessels being shown up on color Doppler imaging. It's important to utilize color Doppler in these views because it helps you visualize this vasculature, which can be relevant in terms of performing screens, but also in terms of doing interventional procedures like draining a Baker cyst or so on. And for PTs in dry needling, it can be helpful as well. We'll go on to the abnormal structures now. And with these, the first one I'll go on is the suprapatellar joint recess. As you notice in this view on the left side, you see that there is that anechoic fusion I was talking about between the two fat pads and the overlying quadriceps tendon. This view does not show a really good image of the quadriceps tendon, but there is some hyperechoic presentation noted around here. And this fluid was noticed in this case, where this case actually had a history of previous meniscal damage as well. On the right side, you see the same patient with the fluid present in the short axis. And as you go on, you'd notice the same patient on the left side in this view. We were able to get the view for the femoral cartilage a few weeks later. So it shows a little bit of thickening of this cartilage, which may be at this point primarily due to that collection of the joint fluid, and it was not like she grew the cartilage. So also here you can actually now note the quadriceps tendon having a little bit more of that sprain strain type of injury. So it kind of cleared out as time passed. Where on the right side, this patient is showing basically arthritic changes of that cartilage when you notice that joint space kind of reducing as we play this video. And on the other end, this is the medial end, that is the lateral end of the femoral condyle. And you notice how that cartilage not only looks a little bit thinner on this side, the quality of that image is also more hyperechoic. Hyperechoic. That shows how the cartilage starts wearing out by regular rubbing of through the years and decades of use and can cause pain. You'd also notice a small little osteophyte that's hanging on at that medial edge that sometimes will cause the irritation. And if you also see how it creates this sharp white presentation, which mostly shows up as when you're bending and extending your knee, that osteophyte is rubbing into the soft tissue above it, causing that quadriceps to create some type of fibrosis. And it can be painful as well. Going on further, we look at the acute suprapatellar anterior joint effusion. Also, this is the same case as I was talking about before with the possible medial meniscus damage. This video I'm bringing in to show you so that what point I'm making here is to examine that fluid in its entirety from medial to lateral as you go through and from proximal to distal, just making sure that you're looking at everything through these videos and not just localizing yourself to a little bit of the imaging. As you go ahead, we're looking at a quadriceps tendon tear in the superior pole of patella. Well, it is sitting right in the middle. As you notice, this whole thing is a quadriceps tendon, and you notice there are some more irritations in that tendon, minor ones, but a quick little small tear hanging right in the middle. And we're looking at this at the 90-degree flexed angle for that quadriceps tendon by screening a little bit more proximally on that tendon. As we go on, we're looking at the distal patellar tendinosis here. I kind of made a point to measure this for you guys. It just kind of shows how the thickening of the tendinosis shows up over time. Plus, you see how that patellar fibular echotexture from here, which is nice and bright, starts becoming a little bit more dark and hyperechoic. There's a small little enthesophyte, which is like a traction spur building up here, causing pain to this patient as well. Again, make sure that you're evaluating these patients in both views. Now, this is another patient similarly showing a larger enthesophyte and some level of tendinopathy as well. So you notice this hyperechoic growth of that bone is kind of intervening within that tendon fiber, and you see this posterior acoustic shadowing right below it that also shows up and confirms that this is definitely a bone hanging in there. And you see the same patient with multiple little osteophytes and enthesophytes hanging in between there. Definitely this was a cause of pain for this patient. The study kind of brings up the value of dry needling and tendinopathy, and this was a 2020 narrative review that suggested where dry needling has a low risk, it is a relatively inexpensive treatment for the patients, and it's minimally invasive. And I would make a point here that if it is attempted, it's best attempted under imaging, so you are directly going to the tendon's specific location and not interjecting into any other space. Another example here is a patellar tendon tear. So we saw a quadriceps tendon tear. Now this one's a similar, but a patellar tendon tear. You notice how this kind of shows in the same way as the other one did. But again, definitely this was a cause of pain for the patient. And this has kind of extended for this specific patient for a good long period of time. So it was a chronic one. And this one now going to the medial side, we're actually looking at the medial meniscus as well as the MCL. So as you look at this part, you can see this hypoechoic straight line going down into the meniscus, while you also notice I've marked these two markers here, so showing that there is some level of subluxation of that meniscus. It's not a super high amount of subluxation, but it's definitely a little bit there. Again, it kind of piques my curiosity that how far deep that tear might be, and is it actually moving the meniscus out or not? Here comes a point normally to evaluate these structures in dynamic view. What I've also made a point to note here is this little arrow pointing up here that basically shows the MCL attachment to that meniscofemoral component. So the deep MCL seems to be sprained in this area as well. Many times the deep MCL portion is sprained more than the superficial portion of it. That's what the current day literature is stating. When you look at the right side, here you notice the same thing happening here. It also kind of connects to the joint space, sometimes relates to fluid that is part of the joint kind of trying to extrude out, adding up to a cyst associated with the meniscal tear as well. I talked about the dynamic evaluation. So this is what shows how a dynamic evaluation is conducted. So you make sure you keep your probe steady on the patient, and you're trying to evaluate with inflection and extension of that joint. Later on in the part of this video, you notice how that hyperechoic meniscus, as we move it, it will start trying to pop out of the joint right at this point as the patient flexes the joint. So you notice right around in here where you see that popping up of that meniscus comes out. And yes, it was a point of pain because that was severely irritating that joint. And you can also notice a tiny little tear hanging in that meniscus right at the end of it. It's not a major one, but definitely when there is a subluxation, it's good to kind of understand that there might be some other problem while doing rehab and taking it into consideration when planning their rehab as well in your clinics. This one shows medial collateral ligament sprain, while, as I said, the MCL is a long ligament. So you notice that in its longitudinal view towards the MCL, right around there, it's sort of a grade 2, grade 1 sort of a sprain. It's not a major one, but it does present in that area, and not so much at the distal aspect. You see a clean MCL at the further end of this video. As we move on ahead, this is a little bit of a severe case with the MCL sprain, which also shows a Pellegrini-Stida sign. In this case, this was a type 2, which is also known as the teardrop pattern lesion of the Pellegrini-Stida sign, because these type of signs do not associate themselves with the femoral attachment. So when you look at this on the right side of the screen, you notice that the Pellegrini-Stida sign, which is basically this hyperechoic presentation which pops up as the video goes on in between the ligament with its proximal attachment on the femur, it kind of shows up right around there. And it was severely painful for this patient in general because the pain was going on for a little bit of a while. When patient came to us, she was unable to bend her knee even through the acute angles. So we looked at it from this angle and we saw that this was there, which, considering its acuteness, we were giving her time for healing. While most of these Pellegrini-Stida signs and the MCL sprains do heal over time with conservative management, some of them may require surgery. Another video on the left side shows you the value of power Doppler utilized on such cases, where you see how that power Doppler lights up when this kind of inflammatory process and neovascularization is present. As we go ahead, we're looking at the osteophyte deep to the MCL here. Now, this was a unique case where the patient didn't show much about anything else. I mean, they had intact structures and they were relatively less painful by the time the rehab ended. But every time this patient would go on a hiking, he was an avid hiker. So anytime he would go on hiking, you would notice that there would be pain on the medial side of his knee. but the MCL was not irritated in any of the clinical tests. But every time you would move the knee, you'd see how that osteophyte kind of pushes right into that MCL and creates this little tenting effect. And the more repetitions this patient was doing with his hiking process, he would get inflamed and irritated. So there was a lot of activity modification and education that went on with this patient to kind of let them know that this would be an issue. And if that was still a persisting issue, they would need to talk to their doctor about it so that they can get some further management of this osteophyte if that was the only thing causing pain. Deep infrapatellar bursitis shown up in these two images. You can see the left side is a short axis view of that patellar tendon on top, while bottom and just deeper to it, you see this fluid collection, which is more hypoechoic to anechoic type of presentation. And yeah, you can measure these in both views, and you can try and basically prognose them over time, check them, see if they're decreasing while the rehab is going. It's a really good visual tool for your patients to understand this. And this one also shows another deep infrapatellar bursitis. Again, this is the short axis view, and this is the long axis view towards the structures. And you see how that fluid is kind of filled up right and about there underneath the patellar tendon. And it was definitely causing pain. And you can notice a little bit of fluid actually going a little bit over the tendon as well. So they had superficial tendonitis too, but the primary one was of a higher magnitude, was the deeper one. And that's the short axis view that also shows you, again, this kind of brings up a point to look at these images from both ends, making sure that you're screening all the way appropriately. As we go ahead, we're looking at a case of subcutaneous cellulitis. Actually, these are two different cases. On the right side, you see I'm trying to bring up a point of something called cobblestoning. This cobblestoning is accumulation of fluid around the subcutaneous fat. So when that happens, the anechoic fluid kind of separates the fat and it makes it look like cobblestone. So it kind of makes those globules of fat separate, and that appearance happens. Though normally this appearance happens later in the stage of an infection. So in these cases, this specifically showed up that infection right above the quadriceps tendon, right in there, as you note here, and that's the joint space. And in the video on the left, you can actually again see the power Doppler in another case, where you'd note how that power Doppler was lit up when we examined the subcutaneous tissue with that infection. This was an early acute infection in this patient. So, and if you notice a little bit more intricately, you could also see a tiny bit of these white echogenic dots that are appearing all through. To my understanding, I normally consider them, if they are echogenic like that, they may or may not have a little bit of comet tail to them, but they can be gas bubbles that the bacteria produces. Now, clinically, this patient had a visual yellowish tinge to that incision. This was a TKR patient, and the incision was looking somewhat like that. So we had referred the patient back to the doc, and with all the clinical findings and the ultrasound findings, and she was put on antibiotic treatment, and that definitely helped on controlling the infection. In cases of cellulitis specifically, clinical examination definitely forms an important tool here. So checking for erythema, pain, swelling, warmth, definitely brings up the signs for cellulitis, while you bring in the ultrasound findings or the hyperemia on Doppler, sometimes cobblestoning in late phases, perifascial fluid, and the degree of subcutaneous edema. And this can all be put into a picture, clubbed together. We can refer the patient out to the medical team for proper management. As we go on, looking at Baker cyst. So this is one of the most common cysts that may happen in patients, specifically with arthritic changes over time. So these can be sometimes painful, sometimes they are not painful. In this case, this was definitely painful, and this is one patient with bilateral Baker cysts. So this can be noted within the, if you notice on the left side, I've kind of marked them as medial laterals, so kind of understanding the orientation, but it is between the medial gastrocnemius belly, muscle belly, as well as the tendon. And then you notice on the other end, it is the semimembranosus tendon. And an important thing to find on a Baker cyst always is this neck. This kind of a little chicken neck that goes in and it kind of connects with the joint itself. This is super, super important to find because that kind of separates it from other type of cysts and other structures. So when you find that, you can definitely say that the joint fluid is actually adding into the space and creating this Baker cyst. Obviously, it sometimes can be drained. Sometimes people get better without the drainage as well. There is a chance that these cysts can burst, and if they do, they need to be properly managed. I do bring in a point here that using color or power Doppler for your popliteal vessels when you're trying to drain a Baker cyst is very important. So making sure it's not too time consuming. All you need to do is just put that power Doppler signal or color Doppler signal on. In this case, like you visualize, just make sure that you're not into any of the vessels while you're trying to drain. And on the other hand, if you're trying to do dry needles, make sure you're not putting a needle into a cyst or a vessel. This further image is provided to me by my esteemed colleague, a senior colleague at the AOPT Imaging SIG. He's also the president there, Dr. Bruno Steiner at Washington Center for Bleeding Disorders. And he was gracious enough to give me this. It shows a lateral patellofemoral recess hemarthrosis. And this is super important because ultrasound brings up a very important point of differentiating between different types of fluids on the imaging. So you can differentiate a hemarthrosis with a regular joint inflammation, with a synovial hypertrophy, and this can be done by the visualization of the quality of fluid as well as the compressibility of the fluid. A study that was done in 2018 by Nguyen and colleagues that showed that muscus can pick up the hemarthrosis even at bare minimum 5% concentration in the joint space, while the MRIs cannot do that. So this was a really good finding noted through this study. Therefore, I mean, I would definitely use this in a point of care setting, especially to make sure you can get to these point of care ultrasound machines very quickly, but scheduling an MRI takes a lot of time. So getting to this and making sure as PTs, we are not putting weight bearing on blood-filled joints, that is very important because we know from studies that the joints can be damaged when the hemarthrotic joints are being loaded with weight bearing. Now, if you notice that there's something's not right on the right side image, that is entirely correct. But this patient came to us with the image, with the contralateral side that was involved. So we were treating this patient for an ACL graft on the other leg, while the autograft was taken from this side. So in such a case, she was getting really good and better with her ACL rehab, but the other side started hurting whenever she got more and more progressive in her rehab. So we made a point to look at the other side and the graft side, and this is what it still showed, which kind of pretty much is explanatory here, that the quadriceps tendon autograft site was not healed appropriately. So therefore, we educated this patient to kind of tone a little bit down on her rehab and let this tissue heal, while we also focused a little bit more towards this side of the joint to start helping this area heal faster. So many a times this can happen because patients and clinicians all together are focused so much on the surgical side that the non-surgical side, which is still technically a surgical side, is not being paid attention for. This next image shows you a normal medial gastrocnemius muscle where you can see nice, and this is a panoramic view, you can see those nice fibrillar ecotextures of the medial gastrocnemius being formed from all the way up of the knee joint, all the way down to forming that Achilles tendon. And then what happens in a tear? This next slide kind of shows you, this is one of our TKR patients that was right there close to a discharge, but somehow got this medial gastrocnemius tear. The good point that I want to make here is that we were able to timely evaluate this tear all together. If you can notice, the tear is pretty decently present. This is a mixed echogenic tear with some bleed hanging in the middle. And you can see how the disruption of those fibrillar ecotexture fibers have been shown here. And we were able to monitor this, give her the peace of mind to know what the diagnosis is, because she did go to the ER with this pain, and they did not diagnose her with the tear at that given point of time. So the next day we were able to. This is a case which kind of shows how the patellar tendon looks after a repair. So I do want to bring this up. Why I bring this specific slide is because of these white dots. These white dots are actually sutures through the patellar tendon, and it also shows the posterior shadowing off from the sutures. You can monitor these patients over time, and as with other cases, you can guide their rehab and loading of the tissues based on how their internal anatomy looks. You can look at this cross-sectional view of the tendon in the same patient, where it shows you how these sutures kind of wrap around, and how, as we kind of screen all the way, they can actually go through the tendon, holding on to the tendon. As you notice, these acoustic shadows that are present, they are not showing any kind of damages, but these are the shadowing from the suture, so they are kind of a little bit of an artifact. So, but again, this helps us in understanding how the guidance can help, because this patient, specifically speaking, came to us for the second time. His other patellar tendon was also repaired, but this one was monitored a lot more closely, and we had good results with this patient. This is a case where we found out that the patient was having some pain a lot longer after doing in the rehab, like somewhere around that 13 weeks time frame after a fracture in the tibial tuberosity. It was a young case, and as you notice on that video, how this screw kind of pops into play, and it is showing right underneath that patellar tendon. And every time this patient would try to do an extension of the knee in long arc quad, short arc quads, he would have a lot of pain and was unable to do it. You'd note that the other screws are well within their range and sitting in the bony cortex under the periosteum, or right at the level of periosteum, but that specific one was hanging out. You can see the same patient in the short axis view, where you note how these hyperechoic metal screws show up here, while as we go to this outer aspect, that screw kind of bumps up and it pushes into the patellar tendon. And a no-brainer, this was causing pain and inflammation around that area every time he would try to do that. So this became a referral for the surgeon, and we had to let the patient take some break, and then was managed later on, again conservatively, as they decided to continue conservative management. This also shows the same screw and how it kind of irritates the area in this regard. The same screw will also be shown in this longitudinal view, and you can again see how it pushes into the tendon. You can see those nice serrations of the screw with no doubt. And also what you see is that mixed echogenic presentation of the tissues around, causing the inflammation and pain to this patient. Some takeaway points from this webinar in rehab and MSK settings in general, from point of care settings. The ultrasound helps in aiding differential diagnosis as within our outpatient clinics. So it should definitely form a daily routine care, a part of routine care. And evaluation of contralateral extremity is available. You can't do 2 MRIs for each knee and hips all the time. It's time consuming, it's monetarily expensive, where ultrasounds are super cheap, can be done right in the point of care setting. Tracking of the repaired tissue after surgery or injured tissue after an injury is of utmost importance and can aid and guide the rehab and treatment over time. It is time-saving and triaging, as you've noticed how in infections you can catch these things early on. In cases of loose screws, it can pick up this stuff. And a dynamic evaluation is always a plus with dynamic ultrasounds in the point-of-care settings. You can also note, as I said, for stability of these screws, nails, and plates during the surgery, plus any kind of infectious findings sometimes of rejection of these ORIFs can be also noted with power Doppler and other imaging. And you can make these decisions of returning to sport and or to general daily activities based on the clinical findings, plus in addition to that, the ultrasonographic findings as well. And last but not the least, it can help with the dry needling and injections and all of the interventional guides with ultrasound. Now I do have a pop quiz for you. After this, a little bit of a lecture. The first question I have is hanging here, and Daria, would you mind bringing that up for the people up here as well?
Right, so you should see the question on the screen. You can choose the best option, you may think, and we'll give about a minute for everyone to respond. And then we'll comment. See, we have about 25% responded, so. Also just wanted to mention this is the highest number of people we have joining live for the webinar. We have about 330 of you. So thank you again for taking the time out of your busy days to join the webinar and learn with us.
Thank you. Absolutely. Thank you for coming.
All right. So we have about half of people who are here answered. So I'm going to give another 10 seconds for everyone to catch up, and then we'll go to the results.
Awesome.
All right. Okay, I'm going to share the results. So we have 2 with 40% is A, and then 55% answered C. Go ahead.
That is correct. Yeah. So 55% answer C, that is good. Yeah. So the cartilage, when it's healthy, it's going to look more of a hyperechoic type of a presentation of that cartilage. So it would not be hyperechoic. That would show a little bit of damage to that cartilage, some fibrosis over time. It can also suggest calcifications of the cartilage, but a hyperechoic is more or less a healthy, and it definitely needs to be uniform from side to side.
Great. Great. Moving on. Okay, now I see people starting to respond. So again, we'll take about a minute. We have about 40% who answered. I'm seeing the numbers go up. So we'll give another 20 seconds. Right. See, everyone is kind of slowing down. So let's go to the results. And C is the correct answer. We have 52% who answered correctly. The next would be B.
That is
so
B.
People are a bit confused with B at 20%. So
Yes. So as I said, the medial meniscus actually connects with the deeper fibers of the MCL, while the lateral meniscus does not connect with the fibers of the LCL. So when injuries may happen, the medial meniscus and the MCL may get injured together. So therefore, third would be the answer for this one.
Right. Right. Last question. Everyone is very quick on this one. So see the numbers go up very fast.
That is good. It just came up, so I was anticipating that.
Okay. Half of you already answered, so this is going fast. So I'll give another 15 seconds for everyone to catch up. All right, I'm gonna share the results now. So the correct answer is number 4, which 81% of you answered correctly, but we had some people who answered 1 and 2. So do you want to comment on that?
Right. So 1 and 2, I think they can get confusing with the fourth one, because the question would be, how do sutures appear? So sutures primarily appear hyperechoic because they are a lot more tighter and they are echogenic compared to the tendon that is beside it. So the ultrasound beam picks up the sharper contrast, and it actually takes the density of that suture and it shows bright white, while the hypoechogenicity and the anechoic presentation would lie just below the suture. So it might block the view of the ultrasound sometimes. Therefore, you may see that darkness. So I think, yes, it was a bit confusing, but I do see the number of 81% picking it up good. So that's awesome.
Yes. Thank you, everyone. I have one more question for everyone. This is just before you leave, we also have, a Q&A session, but on your screen, you should be able to see a question about, did you enjoy this presentation? Do you have any feedback for us so we can plan further sessions for you? But we can, it will stay there, so take your time answering that. And we'll move into the Q&A portion of our presentation. We have 2 questions that have been submitted to us. And then if you still have questions, feel free to drop them into the Q&A chat. So the first question is, how quickly do you recommend physical therapy sessions post-knee surgery?
So it varies. The answer would depend on multiple factors. One, the type of surgery, because again, there could be so many different type of surgeries in the knee joint. If we are looking at patella tendon repair, quad tendon repair, you're looking at meniscectomies, more or less nowadays, the response time to get to rehab is fast. So most surgeons would want their patients to get back on their feet. TKRs, we have seen patients as early as the 2nd day or the 3rd day, or even the first day in-house in the hospital itself. Looking at other repairs, anywhere between a week to 2 weeks is normally a time frame. And again, it not just depends on how quickly a patient should go, but sometimes the real life factors come into play, how quickly they're able to get into a clinic. That also dictates that. So but again, I think 1st week to 2nd week would be a good time frame for most surgeries, unless indicated otherwise by the surgeon or the procedure itself.
Thank you. All right, next question. Any sonographic advancement in assessment of meniscus?
So again, with the meniscus, we still are limited in visualizing the meniscus, as I've said. You are able to visualize that distal portion, the thickened triangular fibrocartilaginous portion, and you can see some of those direct findings of a tear, if there is any, and some indirect findings where the fluid can accumulate in the neighboring tissues. But more so than that, again, your clinical exam does not take a backseat. I always perform my clinical exam first, and then if there's a doubt, with the cluster of tests that we have performed, we look at it through an ultrasonographic finding. So it still is a mix between the two in a point of care setting. And currently, the gold standard will still be an MRI if you're looking at any deeper tears. And again, to bring a point, a lot of the tears that are not large, that are not flap tears, that are not folding on themselves in any way, they mostly will heal. Well, I should rephrase that. They take a lot of time to heal, but they can still be given a chance, if I put it that way. And if they don't, then obviously we're going towards an MRI and a surgical consult.
Thank you. There's one more question just came in. How does the meniscus cyst look? Is it separate from MM or at the deep fibers of MCL?
So if you looked at the image of the triangular the triangular meniscus, it has a direct connection. So there is ideally no separation within those fibers right at that level, the medial aspect of the knee joint. And it kind of blends in with the MCL when the MCL forms from the femoral attachment to the tibial attachment. If there is separation between that structure and your clinical exam is actually showing some sort of pain, we are anticipating that there is some damage to the meniscoid structure as well, or the MCL. So the separation may have some level of traumatic incidence to it. It may have a repetitive strain incidence to it. So they ideally should look connected. If they are disconnected with anechoic presentation in between those two, there is something not right. So we would need to check it more.
Great. Well, this was all the questions. I see chat is exploding. Thanking you, Dr. Sachdeva, for the presentation, the knowledge you shared. And thank you everyone for joining and taking the time today. This presentation was recorded. It will be available online on the website next week. You'll also get an email from us. We also encourage you to come back and register for more webinars with the Academy, explore our certification options. As you saw on the screen in the beginning, we offer MSK certification. So feel free to reach out to us. Again, thank you so much for taking the time. Thank you, Dr. Sachdeva, for your knowledge and for your presentation. We hope to see you soon.
Thank you again, and thank you, everybody. Appreciate it, Daria.
Thank you.